The paper is Survival Comparison of Laparoscopic versus Open Curative Gastrectomy for Early and Advanced Gastric Cancer, a matched cohort study by Moisan, Norero, Slako, Crovari, Ibanez, Perez, Pimentel, Guzman, Escalona, Jaruf, Boza, Funke from the Catholic University of Chile. And Dr. Moisan?
Good afternoon. Thank you to SAYES for the opportunity to be here in this meeting. I want to present the experience in laparoscopic gastrectomy in our center, the Catholic University of Chile. I don't have nothing to disclose. The application of laparoscopic gastric surgery has been increasing rapidly in the treatment of early gastric cancer. However, laparoscopic gastrectomy for advanced tumor remains controversial, particularly in terms of oncologic outcomes. The aim of the study is to compare 3-year survival of laparoscopic versus open curative gastrectomy in early and advanced gastric cancer. We performed a retrospective matched cohort study. We include patients between 2002 and 2010 with an R0 curative gastrectomy. The division into open and laparoscopic group was not randomized. The surgeon decided based on their criteria and experience. We matched all laparoscopic cases one by one with open case according to TNM staging and gastrectomy extent via random statistical method. The median follow-up was 26 months for laparoscopic gastrectomy and 40 months for the open group. The surgical technique we consider in this initial experience a gastroesophageal junction tumor, a contraindication to laparoscopic gastrectomy. A D2 lymph node dissection was practiced routinely. A totally laparoscopic technique was used in all laparoscopic cases. The operative specimen was extracted via a fan steel incision. We performed an intracorporeal hand-saw esophagojejunostomy in all laparoscopic total gastrectomy cases. The patient characteristic was similar in both groups regarding sex, the median age, the presence of comorbidity, and the BMI. The gastrectomy extent was 22 total gastrectomy and 9 subtotal gastrectomy for both groups. And the TNM stage distribution was 16 patients for stage 1, 10 patients for stage 2, and 5 patients for stage 3 in both groups. The surgical details, the median operative time was significantly longer in the laparoscopic group, 2050 minutes versus 2010 minutes. The estimated blood loss was significantly lower in the laparoscopic group, 100 milliliters versus 300 milliliters. And the lymph node count was similar in both groups, 35 versus 39. Postoperative outcomes, time to oral intake was significantly shorter in the laparoscopic group, 4 days versus 7 days. Also the length of stay, 7 days versus 11 days. Any early or late complication was similar in both groups, 23% versus 19%. We have only one conversion to open surgery. And patient with postoperative radiochemotherapy was similar in both groups, 6 versus 7 patients. The 3 years recurrence-free survival was similar in both groups, 83% versus 79%. And if we analyze the advanced tumor, also were similar in both groups, 78 versus 69%. And the 3 years overall survival also were similar in both groups, in all series and in advanced tumors. If we analyze the 3 years overall survival stage by stage, there was no difference between groups, 94% versus 100% in stage 1, 89% versus 82% in stage 2, and 50% in stage 3 for both groups. The patient with positive lymph nodes have a similar 3 years overall survival. In conclusion, in this preliminary report, with half of patients with advanced tumors, the 3 years recurrence-free overall and stage-by-stage survival was comparable in laparoscopic and open curative gastrectomy. The number of lymph nodes removed was similar in both groups, and operative bleeding and length of stay were lower, and the operative time was longer in the laparoscopic group than in the open group. Thank you for your attention.
Any questions from the floor?
I'll go ahead and ask one. That's, given that the outcomes were sort of equivalent in the long term and somewhat mixed in the short term, what is going to be your practice moving forward? Will you continue with the laparoscopic? Will you continue doing some of each, or how will you proceed?
No, now we continue only with laparoscopic gastrectomy, and now we include patients with gastroesophageal junction tumors also.
Over here.
Why do you take so much longer to feed them in the open anastomosis?
In the laparoscopic group, we have a protocol, and the operative day 3, we have an oral exam for feeding this patient. But in the open group, we don't have a protocol for the exam. So is the surgeon decide what they is the oral intake in the open group.
Do you think that's biased then? Because the anastomosis should be the same, hopefully.
Yes, I think that the time to oral intake is biased for this reason.
Okay, any other questions? Otherwise, thank you very much.
Thank you.